programs in the past. So good to see you all again in another program. So as a part of the refresher course, we have decided to include a person from India and another international experience so that we'll all learn and adopt whatever we can. And it's basically a platform where we expect a lot of knowledge exchange can happen. So we have two faculty members for today's session. One is Dr. M.R. Rajagopal and we have Dr. Christopher. You all have gone through foundation courses, but for the purpose of introduction, I would like to introduce Dr. Christopher. Dr. Christopher is Associate Professor in the Division of Palliative Medicine in University of New Mexico Health Sciences Center. And he's also Co-Medical Director, New Mexico Palliative Care, ECHO. He's also the Medical Director of Global Palliative Care ECHO Partnership, and he has more than 16 years of experience in palliative care and hospice care. We met Christopher a few months back in Global Palliative Care ECHO platform, and it was we understood that the kind of knowledge transfer that happens in such international platforms. That's why we thought, okay, let's have those experience to our participants who have already gone through our foundation course. Second faculty, we have Dr. Rajagopal. I'm sure you might have had sessions from Dr. Rajagopal in any of this past training programs. He is the director and founder chairman of Valley India, director of WHO Collaborating Center for Training in Kerala. And he, everyone knows that he has been a Padma Shri Award in 2018, and recently he's published a book. If you have not received a copy, you have not read the book, please write to us. It's a book called Walk with the Valley. I'm sure there are a lot of learnings, a lot of reflections in that book. Thank you so much, Dr. Rajagopal and Christopher, for being a part of this program. We have a few participants here who have gone through foundation course in the past. Many of them are related to an organization called CHAI, which is Catholic Health Association of India. So many of these doctors are working in a very, very rural parts of the country where there is no access to primary healthcare even. There are other participants outside CHAI also. Thank you so much, all the doctors, for joining us on time. Over to you, folks.
Wonderful. I just want to say thank you so much for the introduction, and what a joy and honor to be on this session today. I'm just really inspired by the work of all of you, including Palliative India, and everyone who's on today. You're all healthcare leaders, and so I hope that the talk that I share, which is really going to be a global public health palliative care perspective, but I just want to let each of you know that you are leaders in your community and have just the ability to transform the care, and most importantly, the quality of care of so many people. And so I hope one thing that you take away is that these principles are conduits for you to make change. I'm gonna go ahead and share my screen. Wonderful. And feel free, I love interaction. So if you have questions, feel free to put them in the chat. And Dr. Shri, if you can just let me know if there are questions or comments. I know we'll have a discussion period too, but just feel free to make this interactive as well. So,
sure.
I have no disclosures, and so I wanted to start off and just share with you, there are a lot of different definitions for palliative care. I know the World Health Organization has its definition of palliative care. I think it's really important that we start there. Even though this is a refresher course, almost every presentation, no matter what the audience is, I always start to make sure that we have a common foundation of what is palliative care. it's important to pick a definition that speaks to your region and your community. I wanted to share the one that I often use is the Centers to Advance Palliative Care, which they used focus groups to really firm up their definition to speak to communities here in the United States, where I'm located. But it's important that stakeholders first understand the definition of palliative care and its philosophy, so that this way they can garner key stakeholders and interested clinicians and other individuals in this work of palliative care. It's unfortunate that there's this lack of awareness among policymakers, health professionals, and even just the general public about what is palliative care. And most importantly, what are the benefits it can offer to patients and health systems? And so just to remind everyone, palliative care in the medical subspecialty of palliative care medicine, it's specialized medical care for people living with serious illness. It focuses on providing relief from the symptoms and the stress of a serious illness. And the goal is to improve quality of life for both patient and family. Palliative care is provided by a team, and that team can include doctors, nurses, social workers. And the most important piece is others, because others is all encompassing. I think of volunteers, and I think of our village health workers, community health workers, our physiotherapists. It's so broad. So many people can add to this work of palliative care. And we all work together as a team with the patient's doctors or other healthcare teams to add that extra layer of support. It's appropriate at any age and at any stage in a serious illness, and it can be provided along with curative treatments. And I think that piece is so important, because oftentimes we label palliative care as being only end-of-life care. And yet the true benefits of really impacting quality of life are when we introduce it more upstream at the diagnosis of a serious illness. I wanted to just go over some key facts. I think what's important to understand, so the World Health Organization, estimates that 56.8 million people and 25.7 million of those are faced with a serious illness, and 25.7, are in the last year of life, and all of them need palliative care. But yet only 14% of people who need palliative care currently receive it. And so, and that's even despite several organizations around the world saying that it's a basic human right to have access to palliative care, but yet it is so limited. And it's oftentimes non-existent for millions of individuals, especially in low and middle income countries. And so I think we really need to be reminded of that. And for children, 98% of those needing palliative care often live in low and middle income countries, and almost half of them are in Africa. And so the global need of palliative care is just going to continue to grow. Across the world, we have an aging population, and then we have both non-communicable diseases, and some of the communicable diseases are growing. And so palliative care needs are going to grow as well. So what are the barriers and challenges globally to accessing palliative care? And I just did a collage of different topics, but I want you to start thinking, because you could probably add a lot of other barriers and challenges that you face locally. And I want you to know it's tough doing a talk about global perspectives, because I just want you to know every country, every community, like here in New Mexico where I am, I can drive an hour to 2 hours away, and the landscape for palliative care is completely different. I'm here in Albuquerque, which is the main tertiary hospital for the whole entire state. But yet I could drive 2 hours or 3 hours to a community such as Zuni, where I used to work, which is a pueblo. And a pueblo is where we have American Indian Pueblo people who live there, and yet they oftentimes don't have access to hospice. They don't have access to palliative care. There's so many communities within New Mexico itself that don't even have access to just basic end-of-life support, let alone palliative care. And these communities, believe it or not, here in New Mexico, oftentimes don't even have electricity or water in some of our rural communities. And so I just share that just to say that every situation varies very widely, not only within my own state of New Mexico, but just imagine globally. I know each of you face different challenges. So it's just like starting with the definition of palliative care. There's misunderstandings of palliative care. And I think those misconceptions are so important that we clarify, because it's only like oftentimes people think it's only for patients with cancer or only those who are in the last weeks of life. Yet we need to broaden their perspectives, because when it comes down to national health policies and public perceptions, people need to be on the same page about what is palliative care. Other barriers are the scarcity of research, especially in communities that may lack certain resources, and that we need to establish best practices. And so that's critical, is growing that research. We talked about culture and social variation, attitudes around especially death and dying, as well as palliative care. We need to realize that it's varied from community to community, and we have to really put at the forefront aspects of cultural humility to make sure that we're communicating in an appropriate way, especially for people to understand the benefits of palliative care. And then there's restrictive regulations that oftentimes hinder our ability to provide appropriate medications such as opioids and morphine. It's just incredible that so many countries even lack access to opioids, which is kind of especially a key with addressing symptoms such as pain or dyspnea. And so we need to really work on national policies and programs and resources so that we can train up people in palliative care and have them have access to the tools that they need to provide quality palliative care. There's limited healthcare and financial resources, limited human resources, and that's why we need to think outside of the box. This is not a specialty that is provided just by physicians. It's our nurses, it's our village health workers, it's our volunteers. They all play an important role. And then we also need to understand that we have to integrate our services within the healthcare system. So that's so critical, because oftentimes they're siloed. And then we already spoke a little bit about rural versus urban. There's so many communities that are quite isolated or rural and don't even have access to just basic healthcare, access to basic healthcare services. And so how do we address those issues? And that's why I'm so inspired by Palliative India, because they've thought through a lot of these challenges and thought out of the box of how to deliver palliative care. And I think the big thing too is a lack of training and education. And so that's why I'm so humbled to see all of you on, because it really starts with education so that we can make change. So the World Health Organization really has these 4 pillars for a public health strategy. And, there's developing pertinent policies, drug availability, education, and service implementation. Those are kind of the 4 core pillars. This paper, which I referenced here, Perspectives in International Palliative Care, I just really loved one. They said there should be a 5th principle, which is research. And they were just saying that 5th pillar is important just because there's that paucity of research to inform palliative care practice, especially in low income and middle income countries. And that research can really inform evidence-based practices and contextually bring relevant clinical practices. And especially when there is a lack of infrastructure and mentorship, this is key to having quality research to be able to drive evidence-based practices. They shared in this paper the global partner support model, which I thought was really great. At the core is education, evidence-based practice, and research. And the goals of the core is to really disseminate educational curricula and to equip the knowledge and skills needed to deliver palliative care, and to integrate evidence-based palliative care concepts at the bedside and develop research to fill the gaps in knowledge. And then as you go outside, further out in that circle, you'll notice that there is that second core, which is community engagement, which is critical to allocate resources and foster and promote equitable and quality palliative care. And then you'll notice the global partners that are on the outside. They can be there to support the implementation of this model. And it's critical that the model starts with local leaders such as yourself, because locally, those leaders need to guide the process and adapt the best practices to the circumstances in the context of their community. So I think that's another critical thing, is that each of you play such an important part of knowing what works best in your community. And who are those global partners? And I just wanted to say, I have been so inspired. Like since September, I've been working a part of this global palliative care ECHO partnership. And just like meeting the team at Palliative India, I've been so inspired by the work that's being done across the world. But I want you to know that we can't work in silos. And there's all these amazing regional and international organizations that are really reaching out to help others and to uplift others, so that, making sure that palliative care is truly, palliative care access is a true reality across the world. And so I just included a slide of a number of the different regional and international partners, and we got to work synergistically together. So what are the windows to positive change? What's going to drive us forward, making palliative care access, which is a human right for everyone? How do we improve that access across the world? And so again, each of you can add to this collage of opportunities. I've seen technology. Again, I look at all of you as growing leaders that are out there in your skills, breaking down those silos and having that collaboration, making sure that we're driving palliative care upstream, because it further improves quality of care the earlier that we integrate palliative care concepts. I think, we already talked about the definition, because if we all embrace a common definition of what palliative care is and see the full scope of what it can be, that makes a difference. Realizing that palliative care is not just in the inpatient setting, but really quality palliative care really improves access when we're doing home-based palliative care and integrating it in the outpatient setting as well. And then we talked about expanding who can provide palliative care, and that it's not just physician-driven, that it's a team approach. And just as Palliative India has harnessed community leaders and volunteers and family members, we all need to do this together to make access a reality. And then I think addressing opioid misconceptions is key, and making sure that policies really open up the use of opioids and access to opioids, so that they can be used in an appropriate way and in a controlled way, but yet at the same time, making sure that people have access to have the relief from symptoms such as pain and dyspnea. And innovation and research is also so critical. which brings me to just briefly talk about the ECHO model, which I'm a family practice doctor, primary care doctor. And my journey, my first main position in family medicine was in a very rural community, which I mentioned, which was Zuni, which is a pueblo about 3 hours outside of Albuquerque that had very limited resources. So as a family practice doctor, I did everything. I delivered babies. I did emergency medicine, inpatient medicine. It's called full scope family medicine here in the United States. And so it was such a privilege to have that opportunity. But it was the ECHO model that helped me to be able to do that. And all of you are learning through the ECHO model right now. And so even though I was so far away from the tertiary center, I was able to bring care and services to my patients to that local community. So Dr. Sanjeev Arora had to use innovation, but also he published his results to share it with the world. And the ECHO model was something as a hepatologist, he realized that so few people had access to treat hepatitis B and C. And what was so tragic is that there was oftentimes long wait lists, over 9 months, just to be able to see a specialist to get treatment. But then he realized, why not use technology and leverage technology to create an ECHO community of local leaders who were trained up on how to treat hepatitis. And Dr. Sanjeev Arora was able to reduce the wait times of over 9 months to 2 weeks in our state. And then in addition, he was able to find out that not only was the outcomes of the treatments equivalent to the specialists, but in some cases, it was actually superior just because people trusted the care that they got locally. But I share this model with you to just say that it's been applied to palliative care and many other specialties, because right now we can use technology to leverage scarce resources. We can integrate best practices to reduce disparities, and we can apply case-based learning to master complexity. And we can evaluate and monitor outcomes through quality metrics. So these are the core concepts of the ECHO model. And we need to share that information and process improvement and break down those silos. So the thing is, as a family practice doctor, the ECHO model really empowered me to improve the care of my patients in so many different ways. And the other thing about the ECHO model is that it moves knowledge and not our patients, and it impacts people on so many different levels. It impacts our patients and families, our providers, but also it makes changes within the community affecting health policy. So on a community-wide network, it can really reduce disparities and really propagate all the way through the whole entire system to make change. But I share the ECHO model with you to just say that Dr. Sanjeev Arora had this idea and he thought outside of the box. And he created an innovative disruptor, which has really impacted the world. And you'll see all across the world, there's 59, hub countries, and that number is growing. But it's just amazing the impacts that it's had globally. But I share that with you to say that each of you have amazing ideas inside of ways to think outside of the box to transform your own communities and to create global change. And one of the things that we formed is this Global Palliative Care ECHO partnership, because what we realize is that we're stronger when we work together, when we share ideas and concepts and understandings. We're better together rather than working alone. And so the fact that you're all here today to be able to learn more about palliative care and to grow in your skills, especially your leadership skills, it's really going to transform the world. And each of you are going to be able to make a difference to truly make palliative care access a reality not only in your own communities, but by modeling innovative ways to make change, you will then be able to share that with others. That's going to transform other communities to make palliative care access truly a reality for everyone on this planet. And what an honor to be able to share with you today. And I look forward to a discussion in hearing your ideas as you walk this journey. So thank you. What we'll do is, I think I'll turn it over to Sheree. I think we're going to have a discussion now. So I'm going to stop sharing my slides so we could see each other. So I wonder if people have questions or thoughts or comments. I know I talked about a lot of different things, but I don't know if those things resonated with you. Each of you, I have so much to learn from each of you because you have your own perspectives. And that's what's awesome about being a part of this global community.
I think there was one comment from Dr. Prakash asking, just commenting on another barrier can be doctors' own perspective when they think curing is the main aim of medical practitioners.
Absolutely. And my mentors, and that's one of the things that I've loved about palliative care, is that as providers, we're often taught to fix things, and that our role is to fix it. And we feel a sense of feeling defeated when we can't fix something. And it's so sad that the culture has evolved to be that way, because I think what palliative care has taught me is that, again, it's goal driven, right? So not only is it situation driven based off of the circumstances that someone's in, but it's also goal driven based off of what the patient and the family really wants. And our job is to be present and to be humbled and to learn from our patients and families and the loved ones and the caregivers that are surrounding that person to find out how can we best support them. And sometimes that support, again, is just presence and being there so that they're not alone, and feeling that support.
Thank you, Chris. There are no other questions, but participants, please feel free to unmute and share your comments or questions.
One thing I was going to bring up is it breaks my heart that there are disparities across the world. And I think that's something we mentioned: opioid medications and access to opioids as being one of those disparities. So many countries lack access to just the basic medications that are needed for symptom management. But the other thing too, I'll just share is one of my close family members, Aunt Linda, she went to Addis Ababa in Ethiopia. And as a nurse practitioner, she went to be a palliative care nurse practitioner. She had practiced in oncology for a long time, but she went for 8 years to go to this community and to help with those dying of AIDS in Addis. But what was interesting was when she arrived, all of a sudden they got grant funding to be able to provide medications for HIV/AIDS treatment. And all of a sudden her role went from being a palliative care provider to a primary care provider, because now people who were dying of AIDS were no longer dying of AIDS because they had adequate access to medications to treat this antivirals, to treat this disease. And her job then transformed from being a palliative care nurse practitioner to being a primary care nurse practitioner, treating chronic ailments and complications from the medications. But I just share that as an example it breaks my heart that there are places around the world, and we see this absolutely with cancer treatments, that oftentimes something that can be curable is not, just because of lack of resources. And that's just a reality, or these disparities. And so I just bring that up too, to just say, in some ways, that's a point we all have to remember. And that's why palliative care contextually looks different, especially when we have different access to different resources.
Thank you, Chris. There are no other questions or comments in the chat. Shall we go ahead with the next presenter and then take up the questions after that?
Thank you so much.
Sir, you're muted, sir.
Chris, thank you very much. Thank you for setting the scene. And now we are confident that we can take the discussion forward. Sorry for that wrong screen share. Hi, everybody. Do we all need to look so serious? How about starting with a smile again? Thank you, thank you. I see that only a minority of participants have switched on the video. At least from next session, let us, maybe everybody is not dressed up and makeup not applied, etc. I hope everybody will have the video on next time, because it's necessary for us to see you and interact you as much as possible. So Chris, once more, thank you, and thanks to Sanjeev Arora for giving us this medium for communication. I'll try to avoid any point that Chris has mentioned, but maybe some of them to take it from there more with the Indian context. Of course, I realize that a participant from Myanmar is here. Welcome. And many of the problems are not very different. There are some that are culturally very different, but many of the problems are common between our countries. Now, before I show my screen again, sorry, Prakhar Yanesh, your comment was that doctors focus on care. And I thought that was a very, very important point for us to start with. Genuinely, doctors believe that they have a duty to focus on diseases, diagnose, treat. And they also feel that they have a duty to prolong life, which to them means a beating heart. So maybe that's a good point for me to get started with. I brought that slide to the top just so that I'll be able to respond to Prakash's comment. Many doctors believe that, but this is the official definition of duty of care of the healthcare provider in India. That the duty of care is to mitigate suffering. So Prakhar and everybody else, the presentation will be shared to you. Please look at that executive summary of the document for which I have given the link. The duty of care of the doctor, as officially defined in India by a statutory body of the Government of India, ICMR, is to mitigate suffering. And they add, there exists no exception to this rule. We need to talk about this. We need to talk about this to medical students and have it widely known. And when I talk for the next few minutes, I'll be concentrating on this, mitigating suffering. That also brings up the point that Chris mentioned. He asked us to broaden our perspectives and to define palliative care as appropriate to our countries. And if we think about it, what we need to do is to look for the elements of health-related suffering around us and treat it, obviously, isn't it? In which case, we, as Chris said, we really have to broaden our perspectives. In Chris's country, a spinal injury and paraplegia may not cause the degree of suffering that it will cause in India or Myanmar, where there is a sheer lack of rehabilitation services. Paraplegia here means deepening pressure sores, repeated urinary infections, and miserable death in a few years. We include that in our palliative care because that's suffering. And how about even some acute pains? A child with 60% burns? Oh my God, the agony that something like that causes. And if somebody asks you to help with that pain, will you just walk away? So thank you, Chris, for exhorting us to broaden our perspectives. And definitions can be handcuffs. Let us remove the shackles. And when we see suffering, let us intervene to the best of our possibility, ability. Now, here is another article. Most of the things that I'm talking about are developments in the last 5 years. I'm not going to the time-honored things. You all had training in palliative care. I know. I don't have to. This, again, is another document that I would like you to look at. It's available, open access. And please read the executive summary. The whole document is very long. At least the 5 pages of executive summary will be very informative. Now, that document says that 51 million in low and middle income countries are in serious health-related suffering. But that's only from 20 diseases. How many other problems are there that they have not included? From 20 diseases, their estimate for India is 7 million in serious health-related suffering. So to all the 30 people here, palliative care leaders of India and Myanmar, that this is more likely to be the number that we together have to address. Who was it that said, physicians, the Paracelsus said, physicians are the natural attorneys of the poor. We should only treat the patients that come to us. We have the responsibility to advocate for people in suffering. This is about opioid consumption. By the way, in India, less than 4% of the needy have access to opioids for pain relief. Less than 4%. 96% of people are left behind. And I apologize that I'm showing this slide where many of the things are not readable. But look at this. I've just put in some countries. The opioid consumption distribution is highest in USA and Canada. And then it drops a little bit between Western European countries. We do not want to go here. US and Canada have the so-called opioid epidemic, the other side of the epidemic. That's not what we aspire to. But even for half a century, the Western European country, particularly UK, and then Western European countries have a more balanced opioid consumption. Of course, as we go down to LMICs, things are very different. See, in this list that INCB, in this image that INCB shares, India comes at the very bottom. Of course, all countries are not shown here. But then this is a more interesting diagram. This is again from the Lancet Commission report of 2017. See the distorted image? This shows the world map according to opioid consumption. See the morbid obesity of Canada, USA, and Australia. That's, as I said, that's not where we want to be. Where we would want to be is not the sheer emaciation of India, marasmic, but something like Western European consumption, which is more balanced, where they do not have, of course, zero inappropriate use cannot be aimed for, but they have more or less achieved the balance of reasonable control versus reasonable access. So once more, friends, please read the executive summary of the Lancet Commission report of 2017. But there is one more document that I may request you to see. This is the breakup of the various disease conditions that were brought up by the Global Atlas of Palliative Care from Worldwide Hospice and Palliative Care Association. The previous document that I shared, that also has a sort of distribution map, not very much different. These are the various conditions that they talk about. Important. Some of the participants today are working in institutions which look after only cancer. If it's a cancer hospital, you have no choice. But for the others, limiting palliative care only to cancer is a disease that in India. This is unfair, hugely unfair. Why? Is there a caste system for diseases? In this estimate, only about the 28 plus 0.5, only about 29.3% of all diseases are cancers. It's a variety of other diseases, a lot of neurological problems, including dementia, usually not given attention to. So let us relook at what we are doing and make sure that we do not cause the inequity in care in the name of a disease. Chris, you mentioned research. Thank you for mentioning that. All the research is based Euro-American countries. See, of all the publications in palliative care, according to this study, I know it is a bit old study. Apologies for that. I couldn't find something more recent. But I know today it would not be very different. 93.5% of all publications come from Euro-American countries. So what are we showing? What are we doing here? Going by the evidence created by them. And that's only 15% of the population. 85% of the population is contributing to only to 6.5% of the research. We don't know what are the elements of suffering of our people. We don't know if the solutions that we offer are acceptable. Are we dishing out tablets to be taken forwardly after food when the man or woman has only one meal a day? Are we just treating the disease and the symptoms when the roof is leaking? What kind of lives do our people live and what kind of deaths do they die? Research is not a luxury. Long time back, Jawaharlal Nehru said, it is precisely because we are a low-income country. At that time, we were low-income, that we cannot afford not to do research. Another recent publication I'll quote is about end-of-life care. Dr. Sanghamitra, the Bengali oncologist who is now a Britisher, who does charity work in India, says, no one gets a pain-free and dignified death. Of all the people, the poor, the middle class, or the rich have the worst kinds of deaths. We have the National Cancer Grid. That is a conglomerate of more than 300 cancer organizations in the country. They have together come up with this document called Choosing Wisely India. And one of the 10 guidelines is, do not treat patients with advanced metastatic cancer in the ICU unless there is an acutely reversible event. Friends, you and I know what's happening in our country, including in most of those 300 institutions. People with cancer, if they have, for the crime of having some money in their pockets, die horrible deaths in intensive care units. No justification to it. This article is also available on the Lancet, fairly recent. Now, this is a contrast regarding end-of-life care and intensive care between Europe, Western Europe, and India. This article, published in 2019 in Western Europe, shows that at the end of life, if treatment is considered futile in intensive care units, 90% of people are taken off the life support system and provided palliative care. Whereas in India, 70% of people, even when treatment is considered futile, die on life support systems. They die with their dying process stretched out, prolonging the agony. And the 30% of people who are taken off, mainly because the families insist and because they cannot pay, they are not given palliative care either. These are realities that we are living with, for which we have to keep on working. I know, and I know that it cannot change in a day. But we cannot remain silent. We have to do what we can and demonstrate quality care. So in the context of this end-of-life care, here is the next document that I would like you to look at. The link will reach you through Rajalakshmi. And this is the Lancet Commission report on the value of death, published in 2022. This is all about care at the end of life. Again, it's a long document. At least see the executive summary and the key messages and the 3-page section on India. India deserves some special mention because of the cruelty perpetrated on dying people here. So of the key recommendations of the Lancet Commission on the value of death, one is the management of suffering should sit alongside the extension of life as a goal of healthcare services. Dr. Prakhar Ganesh, not only cure, we have to change that management of suffering. Education and on death, dying, and end-of-life care should be in the curriculum of every health, not only health, and social care students, and in the continuing education of practicing professionals. Who will do it? We together have to do it. Nobody else will come and do it. Their third recommendation is patients and families should be provided with clear information about the uncertainties as well as the potential benefits, risks, and harms of interventions in potentially life-limiting illness to enable more informed decisions. Without giving them information, rational decisions cannot be taken. And in the context of end-of-life care again, if this has not received your attention, it needs to. In 2018, the Supreme Court had come out with a judgment. Now, in 2022, they have revisited it. Supreme Court has come out with a new judgment, sorry, in 2023, just a few months back. Now, one thing that you must remember, and that's for all of us to do, if we live in this country, we are at the risk of having a horrendous death in an ICU. Protect ourselves, protect our patients by encouraging them to create advanced medical directive. The old complicated procedures have been removed. Now you can just create one. There is a model given in Palliative India website. Just go to resources and end of life care. A model advanced directive is given there. You need it for yourself, even though you are young. You need it for your parents and grandparents. And we need it for our patients. So the new decision of the Supreme Court is that if you create it, and if it is countersigned by any gazetted officer or a notary public, it's valid. But I can also tell you what the Supreme Court doesn't say. It is pointless to do this unless you have discussed this in the family. It's most important that your loved ones know what your wishes are and they accede to it. The Supreme Court also recommends withdrawal LI support when treatment is futile. Unfortunately, though they have simplified the process, they still insist on 2 medical boards for withdrawal LI support. So if you're already in the ICU, you can either take the person home, or if they are to do it, they will have to have 2 medical boards. Each board, okay, first one is bound to give the decision in 2 days, and a second one, an external board, preferably in 2 days. But the point is made that the Supreme Court permits withdrawal life support. If somebody says it is illegal to withdraw life support, which is what very often intensivists tell patients and families, it is wrong. Finally, about integration of palliative care. You and I will not be able to do all this task of relieving the suffering of 10 million Indians. World Health Assembly of 2014 advised integration of palliative care into healthcare at all levels, primary, secondary, and tertiary, across the continuum of care. So a couple of minutes about what this integration is. What we mean is, your palliative care unit will achieve only a certain number of patients to be seen. So the more doctors and nurses and other health professionals learn as part of their routine work, that's the only way suffering can be relieved. Like in Chris's country or in a European country, every doctor can prescribe and practice pain management. You don't have to go to a specialized clinic to get oral morphine. This is what we should be aiming for, and this cannot be achieved till we engage with the community and make them aware and make them partners in the process. This integration has to happen at the macro level, at a national policy. It can be at the meso levels, your hospital alone, or just your department, or your clinic, micro. This integration means that if you are an oncologist, when you treat every patient, you also prescribe medicines for symptoms and at least refer the person to a social worker if there is a major social or psychological issue. Well, a lot of work in this area has happened already, more than you think. The field is ripe. India has a national program for palliative care since 2012. In 2014, the law governing opioids was amended. So now it is so much easier to access oral morphine if you are a doctor with some training in pain management. But even more importantly, The new National Health Policy of 2017 includes palliative care, not only in policy, in practice also. Since that time, teaching modules have been created, national and state level trainers have been trained, and from next month, staff of 50,000 family wellness centers will have some exposure to palliative care. And mercifully, from 2019, in undergraduate medical curriculum, and more recently, undergraduate nursing curriculum have included palliative care. So now, the 680 plus medical colleges and the nearly 2,000 nursing colleges in the country will teach palliative care. But how will they? They do not have the faculty trained in doing that. But then, my colleague, our additional director, Dr. Sunil Kumar, and our chief of education, Dr. Sridevi, and Rajalakshmi, and our team all together put their heads together. They created the teaching modules which all medical colleges and nursing colleges, medical colleges can follow. And another working group created similar modules for nursing education also. And also, Dr. Sunil Kumar and Sridevi and colleagues have together Indianized the curriculum of Center for Advancing Palliative Care that Chris mentioned, the CAPC course, with their permission. And tomorrow, in a simple event, the Vice Chancellor of Kerala University Health Sciences will be opening it to all of us. So what does that mean? The faculty of any medical college and the students, medical students also, faculty of nursing colleges can now access these teaching modules and learn with a self-directed course. This I see as a giant step. Whatever I have mentioned here and here are major change makers so that we can expect for some significant improvement in the situation in our countries in the immediate future. Thank you very much for listening. I'm happy to go back to any other slides if necessary, but in the meantime, I shall wait for questions.
Thank you so much, sir. We'll wait for some time for any questions or comments.
Hello. Hey. Reactions, please. There is so much of shared wisdom in this group. They're only wondering who should be the opening batsman or batswoman, as the case may be.
Dr. Rajagopal, can you talk a little bit more about volunteers and the role of volunteers in the community and how that how the future looks for that in India?
Thank you, Chris. This is a vitally important part. What is happening about the community participation? Certainly something remarkable. In the sense, I'll go back to my screen and go back to this image. Now, you know about Astana Declaration. Ladies and gentlemen, in 2018, world nations got together at the capital of Kazakhstan, that's Astana, and reiterated a document that they had together created 40 years back. That was Alma-Ata Declaration. One important point they made was that healthcare cannot be complete unless it is healthcare with the community. If it is something that you throw to them, it will never be complete. Because healthcare, especially in our countries or anywhere, is not only a matter of hospitals and doctors. It is something that mandates food, agriculture, irrigation, sanitation, transport, education. All these have to come together. That can happen only if the community is involved. Unfortunately, globally, we doctors would like to keep our doors locked and not allow the community to come in. What we have made happen here, Chris, please come over and spend a few days with us and see it firsthand, is to open up healthcare to the community. We train volunteers. They initiate palliative care programs. They know the patients, they are from the locality and they understand the problem. And the volunteers from the community have the roots there and they know what the real problem is. They know that this woman is suffering not only because of the symptoms that we saw, but also because the husband is an alcoholic and she has no peace of mind. They know that the children are likely to drop out of school. They make sure that the children do not. In our organization, there are 300 children, more than 300 children, whose education is being supported. I don't do it. Our volunteers do it. So, true health. Health is defined as physical, social, and mental well-being. Physical, social, and mental well-being can be achieved only if it is done with partnership with the community. Chris, but did you have a specific question about this?
No, I think that helps a lot. Just, I think oftentimes, even in the United States, the community is left out and we're siloed as a healthcare institution and we don't include the community. And so your words are inspiring that way. Thank you.
Who is going to come out with the first question? Sridevi, how are we doing for time?
So we are okay. We don't have any case presentation for today because it's a first session, so we have time.
Dr. Prakash Ganesh has raised his hand. Please unmute and speak. Oh no, some problem. You'll have to type it up. Audio is not okay.
Meanwhile, hello, sir.
Yes.
Can you hear me?
We can hear you, doctor.
Yeah. Thank you so much for giving us the deep awareness that palliative care is an integral part of the healthcare system. Widely speaking, the healthcare industry is a kind of, as you have already, you and Mr. Chris pointed out, that it's only like end of life care support. But now more and more we realize, and I wish, as you have, it's been mandatory curriculum and syllabus in medical college as well as in nursing college and institutions. So every health personnel should be aware that it has to be an integral part of our everyday practice. But one thing, practically, I'm a surgeon. So I'm so caught up with my surgeries and taking care of my surgical pre-operative, post-operative, and my OPD, ward rounds, and all that. So, how does it done in any maybe secondary healthcare institution and primary setup? How do we make this palliative care as part of our day-to-day practice?
Dr. Ignatius, thank you for your interest and thank you for, despite the busy life of a surgeon, to be part of this. Can I make a suggestion? I don't know your hospital, I don't know your schedules, but integrating palliative care into your work and demonstrating that integration is the first part. That means, though you are a very busy surgeon with very limited time, you possibly will see an average, an Indian doctor sees 15 times the, that is another Chris Booth did a study and brought it out that an oncologist in India sees about 15 to 18 times the number of patients that a doctor, an oncologist in Canada sees. So there will be limitations of time. Nevertheless, when you acknowledge, you look anxious. When you tell the patient, you look anxious. And you don't have a lot of time to, I know, but at least say, I am going to look after you. All of a sudden, you have already integrated palliative care up to a point. And then, unfortunately, post-operative pain is never treated in India. Maybe, Sridevi, we should have a session only on management of post-operative pain. What is happening in our country is obnoxious. In the corporate hospital, rich hospitals, for 24 hours to 48 hours, there may be an epidural catheter and some pain relief. Most hospitals have nothing. And when that is withdrawn in 24 to 48 hours, no effective pain relief. So, Dr. Ignatius, when you give pain relief and symptom control to your surgical patients, you are already integrating palliative care. And when you light on candle, Dr. Ignatius, there'll be many others, juniors, coming and lighting that candle from you. But Raju and Sri, maybe it'll be just as part of nothing else. Some 1 or 2 sessions on postoperative pain will be, or surgical pains as a whole will be very valuable.
That is, that is part and parcel of the surgical management and post-operative management, relieving pain. I'm not just talking about that, of course, it's done. I am speaking about more of comprehensive palliative care. It's not just taking care of the pain alone.
Dr. Ignatius, where do you work? Which is the city?
This is Dindigul district in Tamil Nadu.
Okay. So maybe Dindigul, to the best of my knowledge, has no dedicated palliative care unit, right? In which case, Dr. Ignatius, despite knowing how busy you are, is it not possible to start a weekly palliative care service, weekly palliative care outpatient clinic? Maybe one afternoon a week, with you train one more doctor, your junior doctor, and a nurse or a couple of nurses. Can we work with you to develop a palliative care service there? It need not be a daily full-time service. And once you start that, I'll tell you what the difference is. Once we worked in a private hospital, because we did not get space anywhere, they had given us a space, allowed us to give free treatment. And after about 6 months, the medical superintendent was met me and said, "Hey, what is this you are doing? Earlier, I used to get only complaints from patients. Now people are writing thanking us. What is happening here?" So this is a possibility. Somebody has to start, Dr. Ignatius. You will not have time, but once you start a palliative care clinic, I'm sure there will be others wanting to do it. We have a facilitation team who work only with people who want to start palliative care. Our project officer will be with you, helping us in the process. But that's not only an answer to Dr. Ignatius. Generally, to all the participants, I'm saying the same thing. If there is no palliative care service in your place, you be the first one to start something. There will be obstacles. The hospital administration may be reluctant. There will be other challenges. Let us identify the challenges and try to overcome them one by one. There's a hand that has gone. Dr. Mami.
Yes, sir. Thank you, sir.
Hi.
And actually, as you said, no, that is very, very true. Since I work in a corporate hospital, and we have started Amritdhara, a center, a palliative care center in itself in Bhubaneswar 2 years back. And your regional coordinator Sunanda also has visited a couple of times to our center. Actually, I am also finding the same things. We have started with few people. Now a lot of doctors are willing to join. Today is the nursing day. So we had a small get together here with nurses and the paramedical staff and few doctors, not from our setup. They just wanted to know about palliative care and just wanted to contribute. So I am totally agree if when our effort will be sincere, so we will definitely give result. Means people will come to join. That is true, sir.
Thank you, Dr. Mami.
But one more thing, sir, I work in Apollo Hospital in Bhubaneswar also. I'm an anesthetist. As you said, the post-operative pain, I keep on talking to the team who are doing this cancer cases and other cases. We have a team, we manage all these things. But if we are talking about dedicated palliative care unit, it's very difficult to, the management now, the current DMS is little bit supportive, but it's very difficult to move ahead in this matter. So can you just help us, to enter?
No, we certainly will do whatever we can, and we'll continue to work. These challenges are inevitable. There will be difficulties. Oh, there will be a lot of difficulties.
Yes, sir. It's really painful. As you said, the advanced cancer patient in ICU and this chemotherapy is the patient is going to die in few more days also. So these are really, and the oncology support is absolutely, it's painful. It's really painful to say, but it's at times it feels depressing. How to go about it, how to really.
So doctor, I earlier mentioned the National Cancer Grid.
Yes.
I'm sure Apollo hospitals must be members. Maybe Raju, please share Dr. Mami's email ID with me also, and we'll see whether we can make an initiative through the National Cancer Grid. Then they have a declared policy of integration of palliative care. And when the suggestion comes from a group of oncologists, that may be better accepted. I am an anesthetist like you. I know how much of resistance there was in the early days, particularly. Now oncologists are voluntarily coming for training. But in corporate hospitals, there could also be fear of losing some of the income. But when they eventually see the goodwill that is generated by palliative care, things may change. Ragesh, you have your hand raised.
Thank you, sir. I work in Amala Hospital. You may know me. I am in
Yes,
charge of
sir.
palliative medicine in Amala Hospital. So my one doubt to ask you was regarding home care services. So we work in Thrissur district. So we have this Pain and Palliative Care Society doing home care service in Thrissur district. Also, Amala Hospital is also covering 5-kilometer radius home care service. So one issue we are facing is that we have limitation in resources to admit the patients in the IP wards because hospital resources are less. So giving free treatment to all these patients will not be feasible at all times. So we want to cover it in the home care services. But the limitation we face is that in our home care service, we are giving maximum up to subcutaneous drips or oral morphine or changing catheters, right? To all limited to or limited to the services. Is it possible to extend services like giving subcutaneous midazolam or subcutaneous glycopyrrolate, bringing these drugs into the home care service and training the family to deliver? This is possible. It's Western is done, I heard. Is it possible now set up to do these things in home care setup?
Jagesh, one word answer is yes.
Okay,
Now,
okay.
see, insulin is administered by the patient or by a family member. That's a much more dangerous medicine than anything that you mentioned.
Okay, okay.
Hypoglycemia, brain damage. But that's permissible. And Indian Association of Palliative Care has, thanks to the initiative of IAPC, they have a position statement. Now, there is no law saying that family members should not administer an injection. Of course not. And this position statement says that it is permissible and it's acceptable practice to give injections by family members, just as a backup. So I'll tell you what we do. If a patient requires, say, cannot take orally, is in pain, cannot come for admission, has to be treated at home, we do not give them ampules of morphine. We believe that may be a bit risky. But we fill up a syringe, maybe a 20 ml syringe, and prepare a morphine injection in such that 1 ml will be equivalent to 1 dose. Whether the patient requires 5 milligrams or 10 milligrams or 1 milligram, we dilute it so that 1 ml is 1 dose and give it to the family member. Ask them just to push it every 4 hours, 1 ml. And in 2 days, they come back with the empty syringe and take another syringe. Coming every 2 days is a mess, but we don't know what else to do. So we actually do that.
There's no legal issues in it. Giving morphine, IV morphine to the home care, there are no legal issues.
There is no law which says that it should not be done. There's no law which says it can be done. In the absence of a law, the courts will go by court judgments, Supreme Court judgments. If not, they go by decisions of statutory bodies, or if nothing else, professional associations guidelines. And that's what we have for this.
So we can give morphine, midazolam loaded syringes to the home givers.
Yes.
Okay.
And if you want a document to show that, look in the IAPC website for the position statement regarding injections at the home.
Okay, okay. Thank you, sir.
Dr. Manish, you had a question, sir? You can unmute and speak.
Good evening, everyone. Good evening, sir. It was a very nice session. I had a query about one, say, starting of a unit in pain and palliative care. So, in a private hospital, in a corporate hospital. So, I am currently working in Rajagopal Cancer Hospital. And as a
Where? Rajagopal. Did you say Rajagopal?
Yes,
oh, I
yes,
see.
Sir,
Okay.
yes, sir.
Okay.
Yes, sir. But I am going there for 2 days from 10 to 4. So after 4 p.m., I am going to another corporate hospital nearby. That's by 4:30. I'm given 4:30 to 7 p.m. That time, I've given the responsibility of starting a pain clinic there in CK Birla Hospital in CMRI,
Okay.
Kolkata. So they're gonna start from next week. So they want me to start as a pain and palliative care unit there. And how my approach is, because I am very young in the field, and they have given me this responsibility of starting the pain clinic. I have done I know some orthopedicians who can refer me some patients, but their oncology unit is very poor. They have an oncology daycare ward, and they have a multi-specialty hospital. As a multi-specialty hospital, they have neuro patients, stroke patients. Those patients are there, and CKD patients and COPD patients mostly. So if I go there at that time, and I want all the departments to know that, yeah, so I can see the patients who need palliative care, early palliative care, and how should my approach be, sir? I am very much confused about it because I have no idea about starting there. I'm absolutely
Yes.
at zero.
Sri and Raju, do we, as part of this refresher course, do we have a session on organizing palliative care?
So this batch, no, but we have not planned, sir.
Session into which this can be squeezed in, because as you can
Yes.
see, this is a vitally important group, and many people are asking the same question, and it's not easy to answer his question in a few sentences or over 5 minutes. So how do you get started? What all do you need? What all manpower is essential? How do you procure oral morphine? How do you procure other medications? Can you do without a trained nurse? Who else do you need? There are so many questions there.
Right.
At the least, Raju, as we are talking, will you please look up Palliative website into the resources and find the link to the section on organizing palliative care. It is either organizing palliative care or organization of palliative care, and share it in the chat box so that everybody can take a look at it and ask questions whenever possible.
Sir,
But-
sorry, sir, we'll share the recording, and I was thinking maybe we can arrange, because Dr. Manish is in the time to start the palliative care unit. Maybe we can put him in touch with the facilitation team earlier than waiting for the session, have a meeting and then decide on how to go forward will be.
Yeah. Yes, Manish, I am here sharing the email ID of the head of our division of facilitation. Shalini and her team will work with you. But then, Sri, I see that this is not only Manish's question.
Yes, sir. Yes.
Yeah, so anyway, give that link to the section on organizing palliative care, and then there it is. The resource link, Manish, is it was Manish's question, wasn't it? Is shared there, and maybe we can answer questions later.
Yes, sir. Sure. I will go through it, sir. Thank you.
Thank you.
And sir, one more thing, sir. I mailed you. I have the CMRI, the Sikivilla hospitals wanted me to join as a full-time anesthetist with a 1-day palliative care or pain unit. But I have stick with the 3-day anesthesia and 3-day palliative care, according to your advice. So it's a bit of running around, but because I don't want a full-time anesthesia right now, because I've gone through it and I want to stick to it.
Very good.
In the long run. So,
excellent.
thank you, sir. Thank you, sir, for this.
So maybe even the busiest people may still find it possible to take half a day away for starting a palliative care in addition to your routine work. May not always be easy, but why does it have to be easy? All the
Right.
easy things have been done by somebody else. Only the difficult things are left.
Yes, sir. Sure. I will go through the.
Okay.
Yes, sir.
Okay, Manish.
Any other questions too, sir? Dr.
Yes, sir, Dr. Atul.
Good evening, sir. Am I audible?
You are audible, Atul.
Sir, it's a great privilege to talk to you. Sir, I am working in palliative care since last 3 years. And I just wanted to ask that that about the living will, that recent amendments which were made in January 2023. And my question is how we can popularize it, that many people are still aware of these amendments made, such as a gazetted officer can sign that on. So, how can we popularize?
Sri and Raju, we do have a session on end of life care, or nothing specific like that?
Sir, we have, but then it is more of, yeah, we have towards the end.
Atul, no easy way except you to barge in on anybody who will listen and keep talking about it. Atul, where do you work?
Sir, I work at Alpha Palliative Care.
Okay. Yeah. You are not part of a big hospital. You are in a full-time palliative care center. So you already do a lot of advocacy. Alpha does a lot of advocacy. So if in IMA meetings, public meetings, wherever possible, you talk about it. This is what we try to do. Difficult, I know, but there is no easier way. Doctors may be less receptive ordinarily. That's what happens usually. But you must remember that if you talk about this subject, there will be a lot of common people who will get up and support you. They may also be very angry, because people who have gone through very painful deaths of their family members in intensive care units, a lot of people live with anger, and they will be your supporters. But all of us have to be part of a movement where we talk about this injustice and do something about it, show another way of doing it. I think more and more of the public are being aware of it. Sri, you must have noticed that in the last few years, people of the middle class or affluent class coming to us are gradually increasing. Not dramatically, but more people are coming, asking for compassionate life and compassionate end. Sangeeta, your hand is up. Sangeeta, where are you from?
I'm from Sikkim.
Oh, yes, Sangeeta, I know you, of course. So,
Good evening, sir.
good evening.
Sir, actually, my question is a bit different one. As you all know, you know very well, sir, I'm the only one doctor. We are two medical specialists in the whole district hospital, and I'm the only one looking after palliative care. It's been 4 to 5 years since last I was trained in 2018 in Karunashray. After that, and because of my interest only, I've been looking after palliative care for my hospital. But sir, because of the being this training from Palliative India, which is to be paid, our doctors hesitate sometimes, and I had been telling them to get trained, but even after repeated tellings, because of the money, that fees, it's like they just deny it, sir. And then I was just thinking if it can be made free. With last time, sir, with repeated request, I could make 4 to 5 of the nurses get trained, sir, and their fees we paid from our some little fund which was for our palliative care program, which I diverted and get them trained with that money, sir. But doctors, they have been just reluctant to get trained, sir. I'm the only one doctor, sir. So last time, you know, also I think sir, I was not well because of my health, because my kidney was having some problems. So I went to Vellore also, sir. Recently, I'm at home also because of my illness. So there is no one to look after. And the morphine also, sir, we have not been given from the district, but we are taking it from the tertiary hospital, that is in the STNM, that state hospital. We are bringing from there and giving to the patients. And after we started palliative care, sir, because it's our very small place, so people they get to know very soon. So there have been lot of patients coming for palliative care, to seek palliative care. But now, as I'm sick, I have been like on medical leave since last 2 months. So I don't know, sir, what is going on. So I wanted more of the doctors to get trained, sir. So if the fees was like made free and all, I was thinking that it's just my opinion, sir, that it would have been easy for us to ask the doctors to get trained, that medical officers and all.
Sir? I think sir's network has gone.
Yes, I think we
Hope
can.
I was audible.
Yes, ma'am, we were audible. I think we can wait for 1 to 2 minutes. Sir will be joining us back.
Okay.
But Raju, I think that's definitely look into it. Please, please write to us,
Absolutely.
Sangeeta, please. That should not be the case. Like that should not be the situation where you are unable to deliver palliative care. So please, we'll be there to help you.
Okay, thank you.
And in the intimation for the new course that Sunil is starting, CAPC course also, it is clearly mentioned that if somebody finds it not possible to pay the fee, you should apply for a scholarship with us. Just write to us. Thank you, Sri. I'm sorry I lost the connection in between and vanished. I see that it is 2 minutes past the scheduled time.
Yes,
Sri.
yes, sir. Yeah, I think we can wind up today's session. Thank you so much, sir, for being with us till 8:30. And Chris is not there, but then I sincerely thank Chris for being up. He just left one meeting and then joined us. So thank you so much, all the participants, and the wonderful interaction that you had. That's what makes this course different from what you had in the foundation course. This is essentially what we want to have in the coming sessions also. Thank you so much, everyone, for being a part of this program, and looking forward for more interaction, more learning and exchange of knowledge. This is not just didactics that is going to happen, but it is understanding your problems and trying to fix whatever we can from our side. Thank you so much, Raju.